I'd like to look past usability for a little bit and start to think about what in industry we might call the added value of functionality. Here is the graph, or one like it, that drove our aims for Sharp-C. And as you can see, the healthcare cost in the United States is by far and away the most expensive in the world. But it's not necessarily the most beneficial. The United States recently slipped to 35th in infant mortality in its rank. Well, there's a complication here. Health information technology was supposed to be what was going to bend that cost curve. And so far, it hasn't been able to do that. And part of the problem is that it's not only contributing to cost, but its impact on healthcare is unpredictable right now. It's very powerful, but right now we have a hit or miss proposition. And of course, by the time it's deployed and you find out that you've missed, that can be very disruptive and even dangerous. So I offer a diagnosis here. And that is, at least in part, health IT functions haven't been co-designed to work smoothly with the manual activity of healthcare. And that manual activity isn't going to go away anytime soon. As a matter of fact, its object is not a computer. Its goal is to improve the health and functioning of the patient. And so the manual activity is tremendously important in healthcare. And if it's not considered as part of that complete system, then we're going to have a problem. It has to support better, appropriate workflow of care. Now, usability testing covers the interface, but it doesn't address the enterprise, the workflow. Now, we have an ineffective treatment that's been tried. I call this paving cow paths. And that's the conservative approach. You're not going to be adventuresome. You're just going to take some manual tasks and kind of reassign those to the computer. That's not what I'm talking about here. What would happen if we made the clinical workflow of care a part of the design instead of an unpredictable response to the design, which is the current situation? So the prescription that I'm proposing here, and that we've been doing research and gathering evidence in favor of, is to co-design the workflow and the HIT to work together to form a matched pair of complementary components to provide measurably better care. And that's the cost justification, or should be, for investing in health IT. And this would be an instance of what in industry is called concurrent engineering. And we're going to design a better workflow to take advantage of the power of health information technology, but to do it in a way that's predictably beneficial. So the protocol is to use something called the Modeling and Analysis Tool Suite for Healthcare, MAF, to co-design the two. And MAF's based on an easily understood, widely accepted standard. We've made some extensions to it that allow us to do trade-off studies with the models where better information resources can be traded off for less use of physical resources. And that's the definition of an efficiency gain. So MAF is intended to make beneficial impact to workflow quantifiable and predictable part of systems design. Okay, so I'll give you a quick case study. This is called Priority Contact. And it's intended to reduce unproductive physician or clinician time to contact patients about test results at the VA where we did this research. There's a policy requirement to contact patients within 14 days regardless of the test result outcome. We won an award for an earlier version of this, and it harvests EHR data to carry out appropriate procedures. And it can also improve the quality. So the physicians participated in this design. What you're looking at on the left-hand side here is the manual workflow. That is the as-is workflow of care for contacting patients. There are 4 priorities depending on the severity of the diagnosis of the test report. And then over here on the right-hand side, you can see there's the streamlined version of what would happen to the workflow when we introduce the priority contact system. Physicians participated in this by virtue of redesigning the workflow in tandem with the software developers. And so this was concurrent engineering, and they were co-designing the workflow of care to be better in an appropriate way, in a measurable way, and at the same time, it would be technically feasible to implement. So we did a formative evaluation. One of the paradoxes of doing a good job of designing health IT is that there are ethical considerations that prevent you from trying out prototypes in realistic situations. And so what we did was use the workflow model and deriving measures of improvement for it as proxy measures for a formative evaluation that would guide the design of the functionality and the interface. And some of that involved reassigning manual tasks to services, but it also involved a better information flow that was in synchrony with the improved workflow. Here's an image of the MathSim simulation engine, and just to show you that it wasn't all smoke and mirrors. And here is the evidence progression. So on the left-hand side, what you see is a comparison of the as-is situation, taking about 30 hours, check that, 39 hours of time to care for about 100 patients in the as-is situation. And we projected and analyzed that that could be reduced into the mid-20s for a substantial saving. Well, we created a version of this for alpha testing, and the testing would be done in situ with anonymized patient data and graduate students serving as mock patients. And here are the results that we got. And what you can see is there's a very good congruence between the predictions of the formative evaluation and the updated model based on actual measured observations. And so we offer this as a demonstration of the technical feasibility to do evidence-based design of health IT and come up with pretty good formative evaluations that guide the design of the functionality and the interface that can be verified in alpha testing and beta testing. And so instead of a hit or miss proposition in terms of the impact on the workflow, what we're doing is building in the impact on the workflow. So our summary here is that you can model the workflow of care to show how it should be improved with health IT, and credible proxy measures can be derived from those models. There's some side effects. It's labor intensive. There's some mitigations for that. Requires advanced skills currently. There's some mitigation for that we're undertaking. But I want to leave you with the admonition of George Box that all models are wrong, but some are useful, and we think we're on to one that's going to be useful. Thank you very much.